I request everyone to be please seated because we're already a little behind the schedule. So the IC today for us is Beyond the Lens, that is navigating cataract surgery in patients who have posterior segment disorders. I request Dr. Sarvanan to please co-chair the session with me. Dr. Manoj, Dr. Sharath, Dr. Sharath Shivan. So I'll start introducing the topic as well as my IC together. My first topic is preoperative posterior segment evaluation and mitigating the postoperative visual surprises. I'm Dr. Harshali from Srinetra Eye Care. Why is evaluating retina before cataract surgery so important? There have been several advances in the IOL technology, and combined with today's marketing about the cataract surgery, the postoperative expectation from the patient has increased markedly. There has been good amount of interest in the post-operative refractive surprises, however, an insufficient focus on the visual surprises associated with macular diseases and other retinal pathologies coexisting with the cataract surgery. The common posterior segment surprises that we often see are the macular edema, age-related macular degeneration, either a macular scar, CNVM, or dry AMD. Vitreomacular interface disorders such as macular hole, ERM, or VMT, and diabetic retinopathy, proliferative and macular edema, retinal detachment, and optic atrophy. So, why is it so essential? It's important to identify any undiagnosed pathology because it can limit the overall outcome in the cataract surgery, and patients may be having unrealistically high expectations. There will be certain conditions such as diabetic macular edema which will worsen post cataract surgery and will require proactive measures. The consent has to go beyond basic if there are associated pathologies. If there's a common thing, like if you find if you find a retinal pathology before the cataract surgery, it becomes a patient's problem, but once you find it after the cataract surgery, it's a surgeon's fault. So, what are the key elements of posterior segment evaluation? One is a careful fundus examination, including the indirect ophthalmoscopy and slit lamp biomicroscopy, utilizing the retinal imaging such as the fundus photography, optical coherence tomography, FFA in select cases, and ultrasound B scan in mature cataracts. History and slit lamp evaluation cannot overcome any of the all these ancillary investigations cannot replace the history and slit lamp evaluation. For example, in this case, a missed RAPD led to an extremely unsatisfied patient in the post-operative period. So the key is to look out for cataract grade that is not consistent with the patient's visual complaints. So fundus evaluation, you need to do a thorough peripheral evaluation, including the indirect ophthalmoscopy along with the slit lamp biomicroscopy. I give you this example with a dense nuclear cataract who complained of a shade in front of his eye. Now, just a slit lamp biomicroscopy would have revealed just a dense cataract and poorly defined macular reflex. However, an indirect ophthalmoscopy in this patient revealed a macula on detachment, which would have been completely missed if the IO was not done. Another case to illustrate, a dense cataract with a hazy view would have entirely missed a proliferative diabetic retinopathy if a careful posterior segment evaluation was not done. To do a OCT or no before a cataract surgery is very controversial. It's more commonly done in patients who are going in for premium lenses. However, to do it normally for every cataract patient is a little controversial. However, there'll be almost around 10% of the cases or 1/10 of the cases who undergo cataract surgery who will be having any missed macular conditions which have been detected only with the optical coherence tomography. So when you're doing a OCT, you have to carefully look at the outer photoreceptor layer, that is the external limiting membrane, the interdigitation zone, and the ellipsoid zone, which indicates the photoreceptor integrity. Macular hole, if missed prior to cataract surgery, may not meet patient's expectation. Also, there will be other considerations such as considering a combined or a stage surgery, which has to be discussed prior to cataract. This all will be discussed by Dr. Sharath in greater details. You may miss a mild macular edema if a slit lamp is not done. Other macular pathologies that may be seen on the OCT are the macular telangiectasia, epiretinal membrane. The role of fundus fluorescein angiography is not too common and can be done in cases of dense cataract with asteroid hyalosis if you are suspecting neovascularization. B-scan can be done in dense cataract, and in cases such as anterior segment coloboma, you may find an underlying retinochoroidal coloboma along with the retinal detachment. Patients who have raised IOP, non-dilating pupil and dense cataract, a B-scan may demonstrate optic nerve head cupping. If there is a posterior complicated cataract with posterior synechiae and non-dilating pupil, you may use ultrasound to detect the choroidal thickening, and that would delay the timing of the cataract surgery. In diabetic patient with uncontrolled diabetes and a dense cataract, he might be harboring a tractional detachment. Sometimes in a mature cataract, you might find a subtle thickening in the macula, and that could indicate a deciform scar, which would again limit the postoperative visual outcome. So, to discuss one of the case, it's a 60-year-old who was extremely unhappy with the cataract surgery done in one eye elsewhere because he was advised intravitreal injection after the cataract surgery. So, he's come for the other eye. The B scan looks normal. The OCT with poor signal strength does show mild edema. So, we proceed with intravitreal injection and then the cataract surgery, explaining the limited visual prognosis to the patient. So there are key decisions that have to be discussed with the patient, such as the appropriate timing for the cataract surgery, whether you're going to do a combined surgery or a stage surgery, and IOL selection. Thank you. I request Dr. Manoj sir to please.
Thank you, Dr. Harshali, for giving me this opportunity. I'll be talking to you on this topic, diabetic retinopathy and cataract, special considerations in retinal disease management to improve the visual outcome. So this is a scenario that most of us would have faced. A patient having diabetic retinopathy with some macular edema. OCT was normal and went ahead with the cataract surgery, and a few months later had a worsening of diabetic macular edema. You can also see NVD in the other eye. And this is another scenario here. Patient with PDR managed with photocoagulation. One eye had a cataract. OCT showed a near normal looking fovea. And 3 weeks after the cataract surgery, patient came with further drop in vision. There was a vitreous hemorrhage in spite of a normal ultrasound preoperatively. So the question is, does cataract surgery lead to progression of diabetic retinopathy? The answer is both yes and no, because earlier the ETDR study showed that there was an increasing trend towards increasing retinopathy progression and worsening visual acuity. And also, large studies have shown that there is a progression of central involving macular edema following cataract surgery. But recent reports have said that if the cataract surgery is uncomplicated, then there's no significant progression of diabetic retinopathy, and that the generalized conclusion that phacoemulsification causes progression of retinopathy is not true. So I'm going to go through some of these situations and try and see how we can get the optimal results. Now let's take the first situation, NPDR without diabetic macular edema and cataract. So we could have two groups of patients. One, patients who are treatment naive macular, meaning in the sense they've not got any focal laser or anti-VEGF in the past. Or you have another situation where the patient has been treated and right now has a normal looking fovea, OCT showing a dry fovea with no central thickness. Now in the first instance, you can directly go ahead with the cataract surgery, and of course, as I said before, there could be a risk of progression, so you need to watch these patients post-operatively. In the second situation, there are two schools of thought. Some people believe that we should do go ahead with a cataract surgery and then follow up the patients. But recently, this concept of prophylactic anti-VEGF therapy has come in, where investigators believe that if you give pre-operative anti-VEGF in these patients, in spite of having a dry macula, these patients end up with less post-operative complications. The cataract surgery can be done 2 weeks after the injection. Because the studies have shown that even with no retinopathy, the risk of developing diabetic macular edema post-operatively is high, and this risk increases in the presence of any pre-existing retinopathy, and it is also directly proportional to the severity of the diabetic retinopathy. Now, with regard to progression of diabetic retinopathy also, these eyes, there is a possibility, especially if the surgery is complicated. So if you have a complicated cataract surgery, you could end up with some progression. There are certain high-risk groups that are identified, and studies have shown that its impact may persist even 5 years after surgery. So coming to the next situation, when you have NPDR with DME and cataract, this is how I would look at it. You look at the density of the cataract. If the view is poor, you could still do an OCT, as even Dr. Harshali showed. Even with the cataract, sometimes you get fairly reasonable OCT images. And if you find diabetic macular edema, it's because you cannot do a laser photocoagulation. It's better to do give an anti-VEGF and then plan an early cataract surgery in these patients. Now, if the cataract is not very dense and you have some reasonable view, and if you on the OCT you see a non-central edema, most likely you may get away by doing a focal laser, and then you can plan the cataract surgery subsequently. But if there is a central edema, you have to think of anti-VEGF steroids followed by cataract surgery. Now, what is the timing of cataract surgery after injection? Because of the short half-life of intravitreal agents, cataract surgery can be done at around 2 weeks after any injection. If you look at the large multicentric trial, the RISE and RIGHT data, surgery was done even at around 7 days after the injection, and they had good outcomes. Now, in patients with DME and not so dense cataract, many studies indicate that you need to wait for at least 6 months for the DME to stabilize, and this causes better post-operative outcomes. But this is not really feasible in clinical practice, and there are other investigators who believe that it's not ideal because maturation of the cataract can jeopardize the surgical safety as well as the monitoring of diabetic retinopathy. Now, the role of OCT, I think, has already been stressed by Dr. Harshali. It is very important not just to differentiate central and non-central diabetic macular edema, but a word of caution, because these images may not be of good quality because of the cataract. So when you comment on finer aspects of the OCT, you should be careful whether the quality of the image is good or not. Morphology of the edema may be important because spongy edemas are known to have better outcomes than CME or SRF eyes. If possible, if you have a reasonably good quality image, look for biomarkers. Some of these biomarkers are poor prognosis: vitreomacular interface abnormalities, drill, ellipsoid zone loss. All this have been associated with poor outcomes. If you have hyperrefractive foci, we now tend to give more steroids in these eyes. In patients with ischemic diabetic macular edemas, the outcomes are poorer. We all know that. It's better to avoid macular laser photocoagulation in these eyes, and these eyes are better treated with anti-VEGF or steroids. Now, regarding the timing of anti-VEGF therapy, once you've decided to give an anti-VEGF therapy, when should you give the anti-VEGF therapy? It is best given before cataract surgery, because we have a large data from all the multicentric trials that if given before cataract surgery, they are less likely to demonstrate macular edema and diabetic retinopathy severity. There are also reports of anti-VEGF given in the perioperative period, that is at the time of cataract surgeon and immediately after the cataract surgery. So this is also an effective strategy to prevent postoperative worsening. We need to consider intravitreal steroids in certain situations. I think most of the people who give injections know this. When you need anti-VEGF more frequently, or when there is systemic side effects, or when you have some OCT findings like extensive hard exudate or hyperreflective foci, and of course in post-vitrectomy situations. Now I'll just touch upon PDR a bit. So we have two situations: in untreated PDR with cataract. So through the cataract you make out there is some kind of a PDR like picture, but then you are not able to grade the PDR well because of the cataract. You should do a B scan, rule out vitreous hemorrhage and macular TRD. If the above are negative, give an anti-VEGF injection, and then plan the cataract surgery. There may be some situations where anti-VEGF is contraindicated. Then these patients know you need to do an early post-op examination and plan a very early PRP as early as 2 weeks. But if the view is reasonable, and if you could classify them as high-risk PDR, you give an anti-VEGF. If it's not high-risk PDR, try and do a PRP. The ETDR has said that PRP should be done before cataract surgery, and you should wait for at least 6 months of stability. And doing it just before cataract surgery should be avoided because of the increased risk of postoperative macular edema. Now, the question is anti-VEGF better than PRP in these situations? The answer may be yes, because even in the non-cataract scenarios, the supremacy of anti-VEGF has been established. So this may be more relevant in cataract eyes because adequate PRP is not possible in these eyes. So definitely anti-VEGF scores over PRP. Now, in a treated patient with PDR, when they come to us with cataract, the first thing we look at is the fundus viewable. And if you have reasonable view of the fundus with good PRP marks, and even if it is an extra macular traction, these are eyes which you can go ahead with the cataract surgery if you think cataract is the reason for the visual loss. But if you have persistent new vessels or pre-retinal hemorrhages in spite of a PRP, then it's inadequate. You need to do an add PRP or give an anti-VEGF. And obvious vitreous hemorrhage and macular TRDs need combined surgeries. Now, if you're unsure, because the clinical examination, because the cataract is not sure, you should do a B scan. B scan is normal, proceed to the cataract surgery. And if it is abnormal vitreous hemorrhage or TRD, you definitely need a combined surgery. There may be also other situations where anti-VEGF should be given in PDR eyes with cataract. This is especially before cataract and vitrectomy procedures because it prevents intraoperative and postoperative bleeding. When you have anterior segment new vessels or neovascular glaucoma associated, or even with a past history of treated new vessels, neovascular glaucoma, it's better to give anti-VEGF. And if there is PDR associated with diabetic macular edema. Postoperatively, these eyes need to be seen very frequently. The first examination can be as early as 1 week, 1 to 2 weeks. If necessary, you need to give an anti-VEGF, you can give it as early as 2 weeks. If PRP needs to be done, you can also do this as early as 2 weeks, but you need to do an LIO PRP. You also need to differentiate postoperatively. When a patient comes with macular edema, you need to differentiate the typical worsening of diabetic macular edema as against pseudophakic macular edema. So if when in doubt, do an FA, because FA shows the typical optic disc staining and the typical petaloid pooling. And the OCT gives you enough clues: hyperreflective foci, intraretinal hard exudates, turbid fluid. Turbid fluid is a sign that tells you that it's diabetic process. So the prognosis is generally good in these patients because nowadays the incidence of complications is less and they have better visual outcomes. But what is clearly established is that patients with mild and moderate NPDR have good outcomes when compared to severe NPDR and PDR eyes. And if you have macular problems, as mentioned there, most of these patients have a poor visual outcome. As Dr. Harshali again said, OCT is a great preoperative tool. So we think that this, in a cataract, OCT may not be good enough. It does pick up most of the changes. As she said, a quarter of patients with cataracts who come for cataract assessment will have some kind of maculopathy. So it is not just identifying the macular edema. You can also identify NVs, as you can see in the photograph there. NVs on the OCT that helps us to identify these problems early. In patients with dense cataract and diabetic retinopathy not gradable, we should do a gonioscopy, rule out the neovascular glaucomas or new NVI or NVI. Look at the other eye, it often gives us a clue. Look at the records. They may carry records that the patient had PDR in the past. Take a good history, explain the prognosis, and these patients require early postoperative management. To conclude, early surgery is better, and the outcomes are better with mild and moderate NPDRs. You treat DME and PDR adequately prior to the cataract surgery whenever possible. When not possible, a postoperative close monitoring is required, especially in DME treated eyes and PDR eyes. And these patients, the postoperative management, either anti-VEGF or PRP, can be done as early as 7 to 14 days. You should know when to refer the case to a VR surgeon, and also should be able to differentiate pseudophakic macular edemas from worsening diabetic macular edema. Thank you.
Thanks, Manoj. I just wanted one question. You were talking about anti-VEGF and steroids when patient is having coexistent cataract as well as DME. Do you consider the biomarkers to decide on what drug to give, or do you side with steroids when you are going for cataract surgery along with the treatment? Like,
now, if the problem is like getting a good OCT picture in the setting of a cataract, if I get a good OCT picture, I would definitely go look at the biomarker signs, and if there are a lot of hyperreflective foci, if I see a lot of turbid intraretinal fluid, then I think these are signs which tell me that no, steroids may be beneficial, because anyway we're going to remove the cataract. So this problem of steroid-induced cataract is not there. It's only the glaucoma. So otherwise, the patient is not a glaucomatous patient, has no risk for family history of glaucoma. Then I think I would use these signs to decide on steroids over anti-VEGF.
Does the audience have any question for Dr. Manoj, because he's going to leave after?
In mic or go?
Yes, sir. So regarding the coexistent use of cataract surgery with Ozurdex, sir, is it a normal procedure which is done, or do we really contemplate it? Because in our institute, we had one odd case in which anticipatory we had given Ozurdex like this, and the patient landed up with a delayed fungal end-off, and that eye was literally lost. So after that, this has become something like a norm. We have stopped even contemplating that for patients like.
I agree with you, 100%. I agree. In our institute, we do not give either anti-VEGF or steroids during cataract surgery. We always do it pre-operatively.
Yes,
we convince the patient that no, it's better to do it pre-operatively. Even we had a bad instance with the steroids.
Yes, sir.
So, but there are reports.
Yes.
If you look at the literature, there are people who are giving it. So I think for the sake of knowledge, yeah.
I have a counterpoint. Like in our hospital, we do it regularly.
Yes, sir.
Together with at the end of the surgery, sometimes even we don't go. The cataracts themselves give.
Yes, sir.
We
That
do advice.
is how we were also doing. Sir.
Actually, we had a study from one of our fellows during a fellowship. She did around 200 cases of concomitant same sitting injection and surgery. She looked at the risk of infection, post-operative, immediate first day post-operative IOP hike, and intraoperative any lens dislocation, iris prolapse complication after the injection. So there was no incidence. So it was proved that it is quite safe to give. So probably just because you had one incident doesn't mean that it is bad.
I totally agreed, sir. I just wanted to highlight that point because we faced that issue.
Right.
Thank you, sir.
Yeah, but Sarana, only my difference opinion is only this. This is like for a general crowd, no. Can this be a carry-home message? That's the only thing. I mean,
the problem with our institute is most of our people are coming from outside the city, so calling them for frequent visits to give injection and then do surgery. So that's why we did this study to show. We wanted ourselves to be sure that we are not causing more harm.
Okay.
And somehow in our study we didn't have any untoward incidents.
Thank you.
There is no data to support or negate, so it's up to you to defend actually. There is no data or there is no recommendation that you should not do it together. So it's up to you to defend actually.
So we are operating on a perfectly right eye or right ward. That means the fungus is coming from probably from outside. It's not a contaminated Ozurdex. It can never happen like that.
What you're saying, point is
No, but sir, physician giving fitness and
We have never done that anyway. I just contemplate.
physician giving fitness and post-operative endophthalmitis, sir. That physician has no role there, sir.
No role there. That is why. Most of the patients are getting away with it. There's no problem. Probably 1 out of 10,000 or 1 lakh may develop, which is not due to Ozurdex. Not even otherwise they will get it.
Yes.
I now request Dr. Sharath Ravi to give his talk on coexisting macular disorders with cataract.
Thank you, Harshali, for this opportunity. I'll be dealing with how to optimize the results of cataract surgery when you have a coexisting macular pathology. In this discussion, we'll be going through some of the common macular pathologies that we encounter in patients who turn up for cataract surgery. And one of the most common is an epiretinal membrane. So epiretinal membranes are semi-transparent vascular fibrocellular membranes which have a contractile property, and their prevalence is usually increasing with age. Therefore, patients with cataract and epiretinal membrane can coexist. So which are the epiretinal membranes that you have to intervene? It depends upon those which could be symptomatic. It depends upon the thickness of the membrane, the amount of retinal distortion, the amount of vitreomacular traction, and the amount of retinal edema. I mean, usually these patients might complain of micropsia, metamorphopsia, or binocular interference, or a monocular diplopia. So this is a very early epiretinal membrane with a mild sheen or a irregular reflex without a distinct edge, and usually there is no obscuration of the underlying blood vessels, and there is no retinal distortion. Whereas in a crinkled cellophane maculopathy, you have a wrinkling of the inner retina, and also you have the retinal vessels appearing tortuous, and vessels seem to be pulled towards an epicenter. Whereas macular puckers are opaque membranes, and these definitely require intervention, and these opaque membranes can cause prominent retinal distortion resulting in foveal ectopia, and the underlying retinal vessels are not visible. And OCT helps in the assessment of these patients with epiretinal membrane because it's seen as a hyperreflective band. You can see the amount of adherence to the underlying retina, which could be a globally adherent membrane or it could be focally adherent. Also, you can visualize the amount of retinal thickness, differentiate between a true hole and a pseudo hole. And this is a stage of the epiretinal membrane Daviston OCT. Stage 1 where you have the foveal pit being present. Stage 2 where the foveal pit is absent and the layers are distinct. And in stage 3 you have an additional ectopic inner foveal layer. And in stage 4 you have the layers getting disrupted. So there are a lot of prognostic signs in epiretinal membrane on OCT where you see a hyperreflective zone at the fovea between the ellipsoid zone and the cost line, and this is referred as the cotton ball sign. And this can over a period of time progress to form acquired vitelliform lesions which are indicative of a poor prognosis. The other poor prognostic signs include an ectopic inner foveal layer or an inner retinal irregularity, presence of cystoid edema, loss of ellipsoid zone, and also an increased central foveal thickness. So following a co-vitrectomy and PVD induction, you stain the ILM with the BBG dye and you start peeling the ILM towards the macula. The ERM creates something like a negative staining, and you pick up the epiretinal membrane towards the macula, and repeated staining with the dye can help in a more complete removal of the ILM as well as the epiretinal membrane. This is another patient with coexisting cataract and epiretinal membrane with a prominent distortion of the macula. You start with a double membrane peel, that is ILM peeling from the end of the arcade, peel towards the macula, and start peeling the epiretinal membrane and complete the peeling of the ILM. Usually a double membrane peel ensures a more complete removal of the epiretinal membrane and reduce recurrence rate. This video is only the peeling of the epiretinal membrane. However, in terms of the two procedures, there is not much difference, visually significant difference in terms of the final visual acuity. This is a patient with coexisting cataract with epiretinal membrane and a prominent spongy edema of the retina who underwent a combined phaco-vitrectomy along with a double membrane peel and SF6 tamponade. At 2 months, you have good resolution of the macular edema with the restoration of the foveal depth and also the good functional improvement. And this is another patient with cataract and epiretinal membrane who underwent a combined surgery with double membrane peel, and post-operatively there was good anatomical and functional improvement. The other thing that you encounter in cataract patients is an interface abnormality. A vitreomacular adhesion and traction are usually two entities of a spectrum during the course of an incomplete PVD. An adhesion usually is characterized by a partial PVD and persistent attachment of the vitreous to the central 3 millimeters and an acute angle between the posterior hyaloid and the inner retinal surface. And however, there is no change in the foveal contour. Whereas in vitreomacular traction, you have the foveal contour being altered either because of a distortion of foveal surface or elevation of the fovea from the RPE, or intraretinal structural changes like a pseudocyst. And based on the width of attachment, you can classify it as either a focal attachment less than 1500 micron attachment, or a broad one where it's more than 1500. And etiology wise, it could be a isolated pathology, or it could be associated with a concurrent whether a new wet AMD or RV or diabetic macular edema. Whereas full thickness holes could also be present along with cataract. These appear as full thickness interruption in retinal layers due to an anteroposterior or a tangential traction. And these are graded according to the gaseous staging or the international VMT classification based on size of hole and the presence or absence of VMT. Following a co-vitrectomy and PVD induction, the ILM is stained with BBG dye, and the ILM is peeled in multiple flaps. You start peeling from the end of the arcade and raise multiple flaps towards the edge of the fovea or the edge of the full thickness hole. You don't completely strip off the ILM from the retinal surface. You leave the flaps adherent to the edge of the fovea. And this is followed by gas tamponade. And normally in cases of traction, vitreomacular traction, you use SF6 tamponade or air, whereas in cases of macular hole, you use a C3F8 tamponade. And this patient with a coexisting cataract with VMT and tractional schisis underwent a combined phaco-vitrectomy with ILM peel and SF6 tamponade. At 1 month postoperatively, there was good anatomical and functional improvement, vision improving to 6, 9 and 6. And this patient who came up for cataract surgery in a left eye on a routine pre-op OCT was detected to have vitreomacular traction. Underwent combined surgery with ILM peel and SF6 tamponade. At 1 week postoperatively, you have the gas fill around 50%, and you see the ILM flaps still being adherent to the edge of the fovea. And this patient with a broad VMT and epiretinal membrane and cataract underwent combined phaco-vitrectomy with double membrane peel and SF6 tamponade, had good anatomical and functional result at the end of 2 months. And this patient with full thickness macular hole and cataract underwent phaco-vitrectomy with an inverted flap of ILM peel and C3F8 tamponade. At 2 months, there was a type 1 closure of the full thickness hole with a good functional improvement. And because of the gas tamponade, sometimes there could be a forward shift of the IOL, as well as there could be a optic capture, posterior synec, as well as decentration of IOLs. These are most common with single piece IOL than with a 3-piece IOL. Regarding IOL selection, the subsequent speaker will talk on it. And this is a patient with pre-existing cataract with macular edema due to a retinal vein occlusion. Patient underwent, we did a combined IOL with the anti-VEGF injection being given at the end of the procedure. At 1 month, you have good resolution of the macular edema and a clear media. But these patients need to be counseled that this is not a one-step procedure. They might require a frequent follow-up so as to pick up any rebound edema. And some of your cataract surgery patients may have such a pathology in the macula where you find cavitations in the inner or the outer retina, or a foveal loss of ellipsoid zone and thinning of the fovea. And these patients with the foveal loss of ellipsoid zone have a final post-op visual acuity less than 612. And these are the patients who have a early loss of vision following the surgery also because of disease progression, rather than the cataract got to do anything with the progression. So therefore, it's important to understand that it's possible to give good results in macular pathologies, and macular pathology per se should not be a deterrent to advise cataract. And with a proper instrumentation and a good skill set, probably you can give a good functional and anatomical result by a combined approach. But patients need to be counseled so that they have realistic expectations regarding the vision, and also regarding post-op care, which includes posturing, which might be crucial in these cases. Thank you.
Thanks, Sharath. Nice talk. So most of the cases you seem to be doing a combined approach for
Yes, sir.
coexistent disorders. Are there any situations where you would prefer a phased, stepwise intervention?
So in our setup, we mostly do a combined procedure, but as you see, there could be all this IOL shift and also the optic capture happening. But when you do a sequential surgery, like first you do the cataract and 2 weeks later you take up for the macular surgery, then usually these complications are less common. But the patient has to go through the trouble of going through a second surgery or a second procedure. That is why we usually take up for a combined surgery. And most of these IOL complications occur in patients who don't lie prone with the gas in situ, and they have a forward shift of IOL or a pupil block happening post-operatively.
In a VMT case, can we just do away with the tamponade if?
Yeah, we could just do air fill. I usually prefer a tamponade, at least air. I fill in with the fluid air exchange at the end of the procedure rather than a saline fill.
Thank you, Dr. Sharath.
Thank you.
I now request Dr. Saravanan, Senior Consultant, HOD of Retina Department, Aravind IK, Coimbatore. He will be talking on managing retinal detachment with cataract and integrated approach.
Thanks, Harshali, for the invitation. So this is not a slides, please. The occurrence of both combined cataract and retinal detachment is not that very common compared to other macular disorders like ARM, macular hole, vitreomacular attraction, and diabetic macular edema. So a little bit uncommon compared to these more common conditions. So when you talk about RD, you have two sort of exudative RD. Usually don't manage with the surgery. It's usually trying to treat the cause of exudative RD, mostly involves medical therapy. But more commonly, what we see is the rheumatologic retinal detachment as well as the traction retinal detachment. So when you have a combined cataract and RD, then it becomes a choice of what to do first, what to do second, or whether to do both. Depending upon the media clarity, I usually try to prefer to do the retina procedure first, as long as the media clarity will allow me to do it. Sometimes even in the presence of posterior subcapsular cataract, if it is not that very dense, I can try to view the retina to a little bit of off center to a peripheral clearer areas and address it, especially in both TRDs as well as REG-RDs. If it is possible, my first choice is always to do the retinal surgery first and then keep the cataract surgery for the second phase, because most of the times we fill it with the oil and we can combine the cataract surgery along with the oil removal. Because in the olden days, if we look at we were always facing out, probably we come from the old school, that time scleral buckling was the first choice for any rheumatologic retinal detachment. And that time there was no, when I was starting to do my surgery, there was no SICS or phaco, most of all ECC patients. And all the time what happens is that when you do surgery, if you have a ECC wound, it will definitely open up during the buckling surgery, and it makes a mess. Once the eye collapses, a lot of pigment dispersion, and it becomes doubly difficult to visualize the posterior segment, especially through an indirect ophthalmoscope, and it makes surgery very, very difficult. So during the buckle era, our choice was always to do the buckling first, and because even if properly sutured, scleral buckling becomes a big issue when you are doing in these cases. But this changed a lot once we had SACS and phaco coming up, and now we are a little bit more comfortable doing combined surgeries compared to the older generation. So when you're treating both together, some of the issues which you face is that wound integrity, as I was talking about. Even in SACS, sometimes eye can collapse. Phaco also, you can put sutures in case the wound is not that very stiff. So again, immediately post-operative, because these patients can have a little bit more dense cataract, sometimes because of the high hypotony, you may have issues during the cataract surgery. The immediate, before we shift to the retina theatre, the occurrence of corneal edema becomes an issue, which can be dealt with peeling the epithelium or using topical glycerin. But more the issue is that when you have a pigment dispersion or bleeding, so usually in these eyes I fill up the anterior chamber with visco till I finish the surgery, because once the pigment starts dispersing, it keeps on coming. How many times you wash, it keeps on coming up again and again during the surgery. So better to fill it up with visco before you proceed, and remove the visco after you finish your retinal procedure. So sometimes you have pupillary constriction, like I showed in the previous photograph. You can use iris hooks. Sometimes you also do iridectomy to sort of enlarge the pupil, especially in patients who have got concomitant significant uveitis with sinus cape. And the longer time, sometimes it can be issue for the patient, because combining, especially in our hospital, we don't do the same person does not do the cataract and the retina, so it becomes an issue when you're dealing with both. And in case you're doing general anesthesia, both has to be done on the same table, so you need a single surgeon to do that. Machine should be available in the same theater. So advantage is that reduce morbidity finishes of a single surgery, and in case of dense cataract, you can clear up the media so that you can do the retina surgery in a proper way. And one more issue is that when you're doing the peripheral vitreous base shaving, you're always afraid of touching the lens, and we have IOL or FAK inside, we are not bothered too much. As I told you, whether it's good to do surgery should be done with the same person or a different person. So ideally, if it's, both surgeries can be done by a single surgeon, doing both cataract and retina, the surgical time and shifting theaters is lesser. But in case you are not, like, I am not a phaco surgeon, but I have to use my next theater colleague to do this. So then the time also becomes issue, and shifting theater also becomes an issue. Then we have what you have here is the as I told you, all this whole thing changed during MIVS era, and now we don't have to suture. So, and also the surgical intervention also becomes easier. So even if you have a freshly operated wound, it becomes much more simpler to operate on these eyes. So after the both the phaco and MIVS, things have considerably become comfortable when you're combining both the steps. So the next question comes, where should we put the incisions? Actually, look at the 3 ports. First, you assume where you want to make your ports, and better not to make your SICS or your phaco incision along the axis of the ports. If you can make it in between these ports, then the chance of the wound opening up intraoperatively and the chance of intraoperative hypotony or iris prolapse all becomes lesser. So try to make your wounds away from your, not in the axis of the sclerotype ports. In case if the wound is not very tight and it's leaking, always don't hesitate to put a suture. It makes my life much more simpler for the retina surgeon who is going to take up for the main step surgery later on. In case the cornea is edematous, you can always peel the epithelium, or if you want to preserve the epithelium in diabetic patients, you can use topical glycerin to make it better. And one more issue is that when you cut off the PC in patients with pseudophakia, you can have air sort of condensing, water vapor condensing when you are doing a fluid exchange. This can be addressed by coating the posterior surface of the IOL with a little bit of visco. That will help you to address that also. And whether to put the IOL in the first step or not, especially when you're doing the recommendation RD, because there is a decrease in the axial length because of the anterior movement of the retina, the axial length calculation and the power calculation becomes an issue. So in case where the bullous retinal attachment, always keep the IOL surgery for the second step, or if we can make the surgery patient aphakic and then do the IOL implantation during the SOR procedure. Again, the choice of tamponade, especially when you're combining, I feel always silicone oil is better because gas is more inflammatory. And not only that, as Sharath already pointed out, the optic capture IOL tends to move forward with Syneque, and optic capture is much more common with gas. So I usually prefer silicone oil because it's a little bit more protected towards the postoperative inflammation part. And as regards to diabetic retinopathy with TRD, I always again prefer to phase it out. My first choice is never to do them together unless there are significant other comorbidities. Reason is that the surgery in a diabetic retinopathy is much more prolonged, and where we have to keep the IOP high because of the bleeding part, and the cornea usually becomes severely edematous towards the end of the surgery. So I always prefer to at least give a gap of 1 to 2 weeks, if it is affordable, to phase out the cataract and the retina surgery. So what we do is first we do the phaco surgery and give a sort of injection at the end of the procedure, to Avastin injection. So it also helps to shrink out the new vessels so that the next surgery, the bleeding, intraoperative bleeding is much lesser. And as regards the choice of IOL, I think the coming speaker also will talk about that. So one last slide is that suppose you are a cataract surgeon who is operating on an already vitrectomized eye. So always be aware that always consider this as a PPC case. Even though the VR surgeon may not tell that he had a lens touch intraoperatively, always assume that there's a lens touch and the PC is weak. So because in case you are operating and you don't take appropriate care to limit your hydrodissection and all those things, you may get a nucleus drop, and especially because there's no vitreous to protect you, the lens will immediately sink down into the posterior vitreous cavity. So any vitrectomized eye, consider like a PPC and do the surgery. Don't assume that it is a good surgery done by always assume that the VR surgeon was a bad person. He's hiding the truth from you, that he had a lens touch and he's not telling you. Assume that way and then carry on the surgery. I'll stop here. Thank you for your attention.
Thank you, Dr. Saravanan. So, one doubt, do we treat any lattice degenerations or holes pre-operatively?
I don't take a special care as regards to both LASIK as well as cataract surgery. Unless you are expecting a PC rent intraoperative, like a PPC, where you expect a PC rent and vitreous disturbance. In those cases, you can do a preoperative barrage laser. But both in LASIK as well as routine cataract surgery, where you don't expect a high risk of PC compromise, I don't advise unless there are other RD, family history of RD, symptomatic floaters and flashes. So unless there is other risk factors, I don't give special consideration for a routine cataract surgery. In case there's a PPC where you have high risk of PC disturbance, then you can do to prevent that actually.
Even for the atrophic holes.
Atrophic holes I don't do. If it's a tear, like I don't change, alter from my routine recommendations what you do for routine. Like suppose the patient is coming with intact lens and clear lens, what's your recommendation? I just follow that for a cataract unless there is significant risk.
I now request Dr. Sharad Shivan to talk on intraocular lens selection and surgical techniques for combined cataract and retina surgery.
Thanks, Dr. Harshali. Today I'll be dealing with IOL selection and surgical techniques in combined phaco-vitrectomy. Initially, phaco-vitrectomy was considered in cases with very significant cataract interfering with the viewing of the retina during the surgery. But nowadays, as the confidence in the procedure increased, we are performing combined vitrectomy for even cases with very minimal lens opacities and even clear lens, so that patient can avoid a subsequent surgery and to just fasten the visual recovery. This is termed as a non-essential phaco-vitrectomy. Besides this, doing a combined approach helps in removal of the complete anterior vitreous and helps to do a complete base dissection without any fear of lens touch. This is important in cases with reg RD with multiple breaks and in diabetic vitrectomy to prevent any anterior hyaloid proliferation. Also, doing a complete vitrectomy allows for a better gas fill and this results in a good tamponade. Coming to the IOL power calculation, our primary aim is not to achieve emmetropia but to settle the vitreoretinal pathology. But now we are able to give excellent result with use of optical biometry and new generation formulas. All of the formulas give excellent result in doing combined vitrectomy. It's always better to avoid multifocal IOLs because the multiple rings in the IOL can create focusing issues. Coming to the material, always acrylic hydrophobic material are preferred over hydrophilic or silicone IOLs. Because if you use a silicone IOL or hydrophilic IOL, it can lead to very dense condensation over the IOL while doing the fax when the posterior capsule is cut open. And also if the chamber is filled with oil, this oil can get stuck to the IOL material and it is completely difficult to remove it completely. So always acrylic hydrophobic material are preferred while doing the combined surgery. There is a study published in Journal of Cataract and Refractive Surgery. It's comparing single piece IOL and multi-piece IOL while doing combined phaco-vitrectomy. The results show that incidence of optic capture and posterior synechial formation is more common with single piece IOL than with multi-piece IOL. Single piece IOL, the optic size is smaller, so it can easily get displaced from the bag while doing a fax or with gas tamponade, especially when the rhexis size is larger. Whereas the 3-piece IOL optic will be larger in size, so it will be more stable inside the bag. There is less chance for displacement. So always, if the rhexis is larger, it's better to go for a multi-piece IOL. Coming to the surgery techniques, incision, you can either choose a temporal phaco or a superior phaco. The advantage with superior phaco is that surgeon doesn't need to change the position in between the surgery. And doing a good rhexis is very important while doing combined phaco-vitrectomy. The rhexis size should be adequate. It should be covering 0.5 to 1 millimeter of the optic margin. If the rhexis is large, there is a chance of IOL get displacing from the back. Sometimes in cases with very dense VH, doing a rhexis without a red glow, doing a rhexis will be difficult. Such case you can stain the capsule nicely with trypan blue and complete the rhexis. The size is very important. Rhexis size is very important. Then coming to the phaco part, you should keep in mind that you should have a clear cornea till the end of the retina procedure. So you use very minimal ultrasound energy. To protect the corneal endothelium, you can use dispersive viscoelastic, and emulsification, you stay in the pupillary plane and do the emulsification. So that at the end of the surgery, you will have a clear cornea. completely remove the nuclear material. Whichever technique you are using, either stop and chop or direct chop, you use minimal ultrasound energy and complete the procedure. And cortex wash, in dense VH case without red glow, cortex wash may be difficult. Carefully remove all the cortex. Sometimes if some peripheral cortex is left behind, that can interfere with your retinal viewing. So completely clear the cortical matter. Then IOL implantation already I have discussed. You can, if the rexus size is adequate, you can always go for a single piece IOL. If you feel the rexus is larger in size, you go for a multi-piece IOL, especially when you are going for a gas tamponade. It's better to go for a multi-piece IOL. Then while do the visco wash thoroughly. Make sure you completely clear the anterior chamber. Sometimes small air bubble can be there in the anterior chamber that can affect your retinal viewing. So always make sure you completely remove the all tiny air bubble in the anterior chamber. And while closing the wound, make sure your anterior chamber is well formed. And always you need a watertight wound. Hydrate the side port and main port, but never overhydrate the wound. Overhydrating the wound can cause a cloudy cornea and affect your retinal viewing. So you should never overhydrate the wound. If you feel that wound is leaking, never hesitate to put a suture. And inserting the trocar cannula, insert the cannula without giving much pressure to the eyeball. You can insert the cannula with a screwing motion, you can go inside. If you do like this, your pressure over the eyeball will be minimal. If you give pressure on the eyeball, your chamber can collapse. So it's better to go inside with a screwing motion. In between, if the chamber get collapsed, you can hydrate the side port, form the anterior chamber, and then proceed with the inserting the cannula. Now you can safely cut the anterior hyaloid without any fear of lens touch. While cutting the anterior hyaloid, it is better to keep the cutter facing sideways or downways. With this, you will avoid the cutting the capsule. In between the surgery, sometimes cornea can get hazy. There can be epithelial edema. Such case, you can peel off the epithelium, or as I mentioned, you can use topical glycerin. Then your viewing will become much better, and you can easily continue the surgery. And always before ending the surgery, before doing a fax and going for a tamponade, always check the anterior chamber, whether anterior chamber is formed, whether IOL is in position, then go for gas and tamponade. So the combined approach, combined phaco-vitrectomy is excellent technique to fasten the visual recovery. If well planned and executed, can give wonderful results for the surgery. Thank you.
Thank you. I had an incident where we had planned for a VIP patient, both macular hole as well as cataract. The cataract was a little bit dense, and by the time they had used to iris hooks, people was not dilating. By the time patient came to my table, it was cornea was quite edematous and a lot of pigmentation. So in those situations, do you try to postpone the surgery, or you would still go ahead and where you feel that the macular hole surgery, the visibility and visualization is going to be a little bit compromised?
If visualization is compromised, better to better postpone the surgery. I'll ask the patient after 2 weeks. I'll review. Once the cornea is clear, then better to proceed.
So we have had a few cases of where the older generation silicone IOLs have a sort of adherent, non-washable silicone oil sticking to that.
Yes.
So in those cases, what do you advise for patients who have either had to do RD surgery with the oil in some of the cases, or we never realized what was the IOLs inside and then did the surgery, and now we have a sticky silicone oil sticking onto the IOL. It sort of forms a chemical bond, not a physical bond. It's a chemical bond. You can never peel it. So what do you suggest for those?
That sticky oil, if it is significantly affecting the vision, then I will remove the IOL and go for a hydrophobic, if it is alka fixating or SF IOL.
Just another doubt. For macular pathology, not along with the retinal surgery, are EDOF lenses okay, or do they also affect the functional
don't have much of experience in this, but I would say that I've done a lot of cases where we have had this ring multifocal IOLs where you have multiple rings, but it didn't seem to affect our visualization intraoperatively that much. I've done almost I have 4 cases of ICL with the high myopia ICL surgery. I had RDs, and those cases also we have done surgery, but it is not that very limiting. Even though we want clear media, the presence of a multifocal IOL, irrespective of whatever type, and also the presence of ICL also in some of the high myopes, we have not had much of an issue with visualization. We can usually get away with a little bit of altering your axis of the globe when you're trying to visualize. So I feel it's not a big no-no as regards to post-segment visualization. So it is okay only.
Thank you, sir. With this, we end the IC. I thank all the speakers and everybody for coming and joining us today. Thank you.